Hello, future colleagues, and welcome to this lecture on wound prevention and management and rehabilitation. I'm Rose Pignataro. I'm one of the faculty in the physical therapy program. I'm also a certified wound care specialist, and I've been a physical therapist for about 30 years. I'm so sorry I won't be able to meet you in person. I've actually met some of you, but not all of you, and I have a long history of working in wound care with occupational therapists, especially when it comes to working with patients who have burns. So today our objectives are to describe the interprofessional wound management team. We'll be reviewing characteristics of the integument or the skin. We'll also look at normal wound healing processes and types of chronic wounds that are commonly encountered in rehab settings. We're going to briefly give an overview of examination and assessment techniques. We were going to practice circulatory assessment and wound management, but there's a video that you can watch on wound management that will be helpful, and I know that you cover circulatory assessment in some of your other classes. We'll also identify common barriers to wound closure and strategies that will help to promote healing. So when we talk about patient-centered care, you can't really have patient-centered care unless you have an interprofessional care team. And that's because patients' needs are often very complex, especially if they have an acute or a chronic wound. So the types of people that might be needed based on the patient's clinical presentation would include various medical specialties like plastic surgery, vascular surgery, neurology, orthopedics, the physiatrist. If the person has a problem ambulating or they have a wound that affects their foot or ankle, they may be seeing podiatry, an orthotist or a prosthetist. They might be seeing the nutritionist or dietary personnel because when we have a wound, our caloric intake and our need for caloric intake and our need for certain vitamins and especially protein really changes. Then we have psychiatry because we know that a lot of chronic wounds or significant acute wounds will come with psychosocial needs that need to be attended to, and spiritual support, the chaplaincy, case management, social work, pharmacy. We'll talk about certain medications that can impede or facilitate wound closure. And then there are certified wound care specialists. And those people can be physical therapists, occupational therapists, they can be nurses, physicians, podiatrists, etc. My CWS is through the American Board of Wound Management, and OTs and PTs through that organization actually take the same exam. So what is the role of a rehabilitation professional when we start talking about wound care? One of the main things is that we need to be able to pinpoint the wound etiology or the cause of the wound. We always want to do our best to address the causes rather than the symptoms only. With a chronic wound, that's a wound that hasn't closed in the expected normal amount of time, and for that reason, we want to figure out what's going wrong. What can we do that will remove those barriers to healing? We also want to take a look at what's placed the patient at risk for wounds in the first place and what we can do to decrease or eliminate the risk of future skin breakdowns. And then for PTs and OTs, it's especially important for us to consider what types of functional impairments the person could have now or might have in the future as a result of this wound. So in terms of basic wound care assessment, the things that we need to think about, first and foremost, are pain. We know that various types of wounds can be very uncomfortable to the patient, and just from a humane perspective, we want to do our best to alleviate that. But also from a physiological perspective, when people have pain, it activates the sympathetic nervous system, and from a healing perspective, what that means is that very often there will be reflexive vasoconstriction at the site of the wound, which restricts blood flow and oxygenation. We also need to be attentive to edema or swelling. We want to check and make sure that the wound site and the affected body part has adequate circulation so that the wound is getting enough blood flow. Sensory testing will help us determine the patient's risk level and what the likelihood of pain is at the wound site. For some people, the absence of pain is actually a problem. When we look at people that have diabetes or other types of neuropathic wounds, It's the loss of protective sensation that contributes in a very large way to their risk of developing problems with their skin and also the risk of delaying care. When we don't have pain, we tend to underestimate the severity of the wound, and that can stop people from seeking out care when they really need it. Signs and symptoms of infection. So if you think about what those might be, there's a big overlap between the signs of infection and the signs of inflammation. So we can talk about warmth, redness, we can talk about pain, but also from a wound perspective, we need to pay attention to the amount of exudate or fluid that's coming out of the wound, the type of fluid that's coming out of the wound. When someone has an infection, the fluid tends to become increased in volume, but also the texture changes. It becomes thicker. Also, the color may change. It can become yellow, white, or green, and there's usually a very distinct odor associated with infection. We need to be attentive to systemic signs of infection too, like the patient running a fever or just feeling generally unwell, nauseous, etc. And again, as rehab professionals, we are very concerned about the location of the wound and the impact of that wound on the patient's functional movements, their ability to carry out their activities of daily living, and whatever the client's occupations might be. And so that really becomes part of a very tailored, individualized assessment for that patient. So the types of interventions that members of the rehab team may do with the patient and their family or caregivers are education and pressure relief or pressure redistribution, and that often has to do with turning and positioning when the person is bedbound, or even how they sit in a chair or a wheelchair. We can talk about offloading through the use of cushions and specialized footwear, assistive devices. The next thing that we need to be attentive to is the choice of dressing. So obviously dressings help to protect the wound and promote healing, but we'll talk a little bit more about matching the type of dressing that we recommend to characteristics of the wound. For instance, if we have a wound that's very dry, we may choose a dressing that's going to be able to add some moisture. Conversely, if the wound is very wet, we'll have to be thinking about an absorbent dressing. Then finally, throughout the wound healing cascade, even well after the wound has actually closed, we'll be talking about the restoration of movement and preventing and minimizing functional limitations. So in terms of wound etiology, depending on your practice setting, you might see a variety of acute wounds or chronic wounds. And the types of chronic wounds that are most common in rehab settings are pressure injuries, vascular ulcers from either arterial or venous insufficiency, or sometimes from a mixed etiology, and then diabetic ulcers, which come from having diabetic peripheral neuropathy. So there are other types of neuropathic ulcers as well from various types of other types of peripheral neuropathy, like chemotherapy-induced peripheral neuropathy or chronic inflammatory demyelinating polyneuropathy. Let's talk a little bit about the structure of the skin, because that can help us understand prognosis for healing based on the depth of the wound. So I'm sure this is a review for you, but the epidermis is the outer layer of the skin. It's about 0.06 to 6 millimeters thick, depending on which region of the body that we're talking about. So if you think about various surfaces of the body, the skin on the face and the eyelids, for instance, is very, very thin in comparison with the skin on the sole of the feet, which is much thicker to meet the physiological demands of walking, weight bearing, etc. Underneath the epidermis, we have the dermis. The dermis is the underlying layer of connective tissue. It contains the capillary network and the lymphatics, which help to drain and nourish the epidermis, provides the oxygen supply. We also have the cutaneous nerve endings within the dermis, and the dermis has two sublayers, the papillary dermis and the reticular dermis. One of the things that helps us in terms of prognosis for healing is the fact that it takes about 14 to 21 days for a new keratinocyte to migrate from the basal layer of the epidermis to the skin surface. And so what that means for us is that if we see a patient who has a partial thickness wound, that involves only the epidermis and is confined to those upper layers of skin. We know that the prognosis for healing based on the amount of time it's going to take a new cell to migrate to the surface is about 2 to 3 weeks. And so we need to keep that in mind, because if we have somebody with a partial thickness wound and they're not healing within 3 weeks, we need to figure out why as soon as possible so that we can go ahead and address those barriers. Then we have the accessory structures of the skin, the hair follicles, the toenails, the fingernails, sebaceous glands, and sweat glands. The reason that the accessory structures are important in wound healing is that accessory structures like the hair follicles and the glands provide little reservoirs of epithelial cells, and those reservoirs of cells can act as a, a resource for reepithelialization when we're dealing with full thickness wounds, or I'm sorry, deep partial thickness wounds rather. So if we have a wound that affects more than just the upper layer of the skin, that extends down into the dermis, if those accessory structures are still intact, the wound will retain the ability to heal not only from the margins, so it's going to generate new epithelial cells from the edges of the wound, but also from any intact accessory structures. So that will decrease the time of healing and improve the patient's prognosis. Subcutaneous tissues, tissues that lie beneath the dermis, include the adipose layer, which functions as a calorie reserve and also helps us with shock absorption and padding. But we need to keep in mind that the adipose tissue is not well vascularized, meaning that when it's exposed, it can actually form a barrier to wound closure. We also have the fascia, the muscle, and the bone. And so knowing where these subcutaneous tissues are with reference to the skin helps us gauge, again, the depth of the wound and the patient's prognosis for healing. The other thing to keep in mind is that if the fascia or any tendons are exposed and the wound becomes infected, infection and bacteria can actually track along those fascial planes or along the length of the tendon. And so during our assessment, we make sure that we're assessing not only the wound site itself, but that we palpate along the length of the tendon or along the length of the fascial plane to make sure that there's not a change in texture or temperature that might point us in the direction of an infection that's starting to travel from the local site into more of a systemic issue. As we age, there are various changes within the integument that actually place us more at risk for wounds and delayed healing. The epidermis and the subdermal adipose layer atrophy or become thinner. Also, the skin loses some of its collagen and elastin content, so it becomes less flexible and pliable. We call that decreased skin turgor. The cells throughout the body have a slower rate of regeneration, and so this is true for the skin as well. Therefore, we adjust the prognosis for healing in patients that are older, especially those who are 65 and older. The sebaceous glands in older skin become less efficient, so there's an overall decrease in moisture level of the skin, and so we have to think about having the patients use a moisturizer to prevent the skin from becoming really dry and friable. In general, we recommend a moisturizer that is water or petroleum based and is also free of any type of harsh fragrances, because the fragrances tend to be alcohol based, and we know that alcohol can further dry the skin. Overall, in older adults, we sometimes see a change in texture that can be described as onion skin. There's less adherence between the epidermis and dermis. That's one of the reasons why we get wrinkles as we get older. But for us, the thing that we have to be concerned about is that the overall results are that that skin becomes more fragile. So people who are older are more vulnerable to skin injuries, and also when they do have a skin injury, it will take longer for them to heal. Let's review the processes and stages of healing in open wounds. They're very similar to the processes and staging of healing in other types of tissues, and knowing what the normal is then helps us to adjust for anybody that might have some type of impairment or pathology. And so this is for a partial thickness non-infected wound in a healthy individual. So this is someone who's free of comorbidities like peripheral vascular disease, diabetes, etc. We also want to keep in mind that these phases are approximate and they do overlap. So even though we make 3 distinct phases, we need to keep in mind that sometimes it's a little hard to distinguish as the body transitions from one phase to the next. Also, many times in chronic wounds, the body will revert to an earlier phase because the healing has been disrupted. We start with, there's 3 phases here, but obviously the first phase is actually hemostasis. When we have an open wound and it's bleeding, the body has to go into the clotting cascade so that we can prevent hemorrhage and the further loss of blood. Then we go into the inflammatory phase, which can last from 4 to 6 days. Often as rehab professionals, we think of inflammation as a negative event, but for wound healing and tissue healing in general, some well-controlled inflammation is actually necessary to kickstart that healing cascade. And then we have the proliferative phase where the new cells are being developed and filling in the wound defect, and the remodeling phase. What I do want to call your attention to is that remodeling phase can last up to 2 years. So if you have a patient who's had a full thickness wound, say a very deep burn for instance, and their scar tissue that is obviously going to develop, that scar tissue will change over a course of 2 years from the time of the injury. So that gives us a very big window to make changes with that patient, especially if we have a wound or a scar that crosses a joint that is impairing that person's mobility. There's still a good prognosis that we can make changes up to 2 years post-injury. Partial thickness wounds are wounds that involve the epidermis only or the epidermis and part of the dermis. So the important thing is that some of the dermis remains intact, and also those skin appendages remain intact. And as we talked about earlier, those skin appendages can form reservoirs of epithelial tissue that can help speed the process of healing. Partial thickness wounds heal primarily by epithelialization, which means that the new keratinocytes and epithelial cells bud and migrate from the wound margins and the intact appendages. And as they begin to proliferate, they come together, and as the defect closes, the mitosis of those new keratinocytes stops because of contact inhibition. In full thickness wounds, the epidermis and the dermis are no longer intact. Full thickness wounds heal primarily through contraction and scar tissue formation. For us, in terms of prevention of recurrence, we need to keep in mind that when a full thickness wound heals, it will lack its original tensile strength. What this means is that the wound will only regain approximately 60 to 70% of its original skin turgor, which then places that patient at risk of future skin breakdown. So our plan of care should include steps to protect that delicate skin so that the person doesn't get a wound in the future at the same site. During the proliferative phase, one of the big things that happens is that the body has to develop new blood vessels if those have been damaged through the wound. And those new blood vessels that are formed through angiogenesis give the wound base a very red, beefy, glossy color. That's called granulation tissue. And I was told by my old mentor, the person that taught me most of what I know about wound care, is that we should think about that granulation tissue almost like a red carpet. And so epidermal cells are kind of snobbish. They're like little tiny queens of England, and they won't march from the wound margin across the surface of the wound unless we have laid down that red carpet first. The red color of that carpet is due to the developing blood supply. And so anything, when we think about it, anything that impairs the development of new blood vessels or anything that forms a barrier to circulation to that wound bed may interfere with the development of the granulation tissue. The other thing for us to think about is that granulation tissue is actually very, very delicate. It's also very valuable because, as we said, the wound won't heal without it. And so once we see it developing, we want to do everything that we can to maintain adequate moisture and to protect that wound with proper dressing. And so here we see not only the granulation tissue in the center of the wound, but if you look at the edges of the wound, you can see evidence of reepithelialization. Those new epithelial cells look like the pink pearly area that's at the wound margin. It used to be, when I first started out as a wound care specialist, we did not subscribe to moist wound healing principles. In fact, just the opposite. And so we thought that moisture at the wound bed actually encouraged the proliferation of bacteria. And so we did everything in our power to dry out the wound. We painted it with iodine, we left it open to the air, all things that we now know through evidence-based practice that actually delay the closure of the wound. With moist wound healing, we know that it promotes the progression of the healing cascade. Those new epithelial cells in the blood vessels cannot develop unless there is adequate moisture at the wound. The moisture that's produced by a wound also contains growth factors and cytokines that help to advance the wound healing cascade. It promotes autolytic debridement, which is where the body and the body's immune system help to rid the wound of any dead tissues or foreign matter and debris that might be present. And it supports something called the current of injury. Our skin acts almost like a battery, where the outside of the skin has a negative charge with respect to the wound bed, the exposed underlying layers of skin. And so that voltage gradient, when wounds heal, we know that opposite charges attract. It actually helps to close the wound, helps the new epithelial cells migrate to cover the deficit. Also, that voltage gradient or the current of injury helps attract certain cells into the area that the body needs for the tissues to heal. So moist wound healing is usually accomplished through the choice of the wound care dressing. I had mentioned earlier that if we have a wound that's very wet, we will choose an absorbent dressing versus a wound that's dry, where we will choose a dressing or a topical agent that can actually add moisture to help support those principles. So when we see patients who have wounds that have not healed within the normal physiological time frame, we need to think about some of the reasons why that wound might be stalled in terms of healing. So in chronic wounds, some of the things that we see are chronic inflammation. So the wound never progresses from the inflammatory stage into the proliferative phase until some type of intervention comes along that helps address these problems. With chronic inflammation, very often what we'll see is that the wound is clogged by necrotic tissue. So the body's having a problem removing that dead tissue on its own. And so the interventions in terms of the plan of care might include debridement or hydrotherapy to help get rid of that dead tissue so the new tissue can come in. Wounds that are in a chronic inflammatory stage often have contamination with debris or bacteria as well. Poor circulation will not allow the wound to have enough nutrients and oxygen in order to heal. I talked about the dry wound bed, how that diminishes the current of injury and takes away some of the growth factors that are necessary. And then for us, especially in patients that are older or patients that have some underlying medical conditions, there might be complicating factors like diabetes, venous or arterial insufficiency, patients with limited mobility due to spinal cord injury or other types of musculoskeletal or neuromuscular impairments. Also, we need to be aware of any type of impairment in sensation, which reduces the patient's ability to detect trauma and other types of skin irritants. Advanced age, we talked about how older adults experience some physiological changes that can impede healing. Poor nutrition, also some of our lifestyle factors, in addition to poor nutrition, things like tobacco use and alcohol use as well. And then repetitive trauma. Let's use an example of somebody that has a wound on the bottom of their foot. If that person continues to ambulate or they're wearing footwear that actually places a lot of tension, friction, and shear at the wound site, we can't really expect that wound to close because it keeps being repeatedly exposed to the forces that caused the wound in the first place. And so that will need to be part of our treatment intervention as well. We can divide the factors that affect wound healing by intrinsic versus extrinsic factors. Intrinsic factors are related to the patient's own individual health and their own body's capacity to heal. Extrinsic factors are factors that are within the patient's environment or even factors that are related to an improper plan of care. So just as a review, some of the intrinsic factors that we talked about are circulatory supply, the presence of infection and inflammation, the patient's age, and lifestyle choices. Extrinsic factors, as a summary, would include things like the choice of dressing based on the moisture level of the wound, also the support surface, whether or not the patient, if the patient is somewhat immobile and is confined to a chair or the bed, how does that support surface contribute to pressure distribution and pressure relief? We also have to think about things that apply mechanical stresses to the wound site, how the person transfers, for instance, or how he or she is ambulating, any types of assistive devices or prosthetics that might also be applying pressure, friction, or shear to that wound site. And then there are certain medications that can contribute to delayed wound closure. So some of the chief medications that can impact wound healing are chemotherapy agents. Chemotherapy agents are medications that are designed to reduce the rate of mitosis in cancerous tissue. Unfortunately, we see that they have an impact on the rate of mitosis throughout the body. That's one of the reasons why people will sometimes lose their hair while they're going through chemotherapy. And so reduced mitosis will slow down the rates of wound healing. Steroids suppress the inflammatory response, and so they can also impact the wound healing cascade. Antibiotics, ironically, can also delay healing. Anticoagulant medication can interfere with the clotting cascade. And then certain topical agents that we sometimes use on the skin or within the wound, such as petroleum and oil-based products. Petroleum and oil do not conduct electricity, and so when we talk about the very small magnitude of electricity that's present in that voltage gradient or current of injury, if there's oil or petroleum in the way, for some people that will actually make the difference in the wound being able to progress from inflammation into proliferation and remodeling. Circulatory problems, peripheral neuropathy, respiratory issues, cardiac issues, those all interfere with the body's ability to provide oxygen, nutrients, and blood to the area that's healing. Renal conditions, liver disease also contribute to delays in healing, and soft tissue diseases, autoimmune conditions like lupus. But of course, there's a very long list, and these are only some of the main issues. So we really have to take a good look at the patient's history and their medical records to identify other potential barriers. We talked about moist wound healing, and the current of injury. So the hydration level or the moisture level of the wound is very, very important. Some of the terminology that we should be aware of is the word desiccation, which indicates that the wound is too dry, and maceration, that indicates that the wound bed has too much moisture, it's too wet. We need to be able to strike a healthy balance, and that's usually related to the choice of dressing. And so here's a picture that shows you what maceration is. If you've ever had a water blister and that blister bursts or drains, and you see that white mushy skin that happens over the roof of the blister, that's what maceration is. And so here we have a picture of somebody who has a venous insufficiency ulcer, which tends to put out a lot of fluid as part of the wound exudate. And if we don't use the right type of dressing, the skin surrounding the wound becomes exposed to too much moisture over time, and it becomes wet and mushy and soft. And the problem with that is that, first of all, it can be very uncomfortable. It could cause pain for the patient, but also that wet, mushy tissue is prone to breakdown. And so if the wound begins to put out so much fluid that the skin around it becomes macerated, that skin around it can break down and also become part of the wound. So the wound actually gets bigger. We talk mostly about chronic wounds because when somebody has a delay in healing, that's when they're most likely to need rehabilitation services like PT and OT. But depending again on setting, we might also see patients with acute wounds like lacerations, skin tears, abrasions, etc. So let's talk about some of those common types of acute wounds. Lacerations are actually the most common type of wound that are seen in the emergency department, and it will depend on what caused the laceration. Here we see a laceration on the dorsum of the hand that has pretty clean wound margins. But there's also a very high risk of contamination and infection, depending on how the person sustained the wound. So cleaning this type of wound before the wound edges are closed is very important. Lots of times this person will require sutures or some type of surgical wound closure. Skin tears are unfortunately very common, especially in older adults. They occur in response to relatively minor trauma, so forces that a younger person may be able to easily withstand on the surface of the skin without any type of lasting repercussion can actually cause an open wound in patients where there's been physiological changes due to aging of the skin. So a lot of times we'll see skin tears on the back of the hand, the forearm, the shins of the patient, areas of the body that are very easily bumped or exposed to shearing or friction. It can happen when the patient is transferring from bed to the wheelchair, if they bump their arm, for instance, on the armrest, or if they're doing a sliding board transfer and they hit the footrest of the wheelchair, if they're walking and they have bad balance and they bump into a piece of furniture or even the door frame. Sometimes the skin is so delicate that it'll just open up. So it can occur over any anatomical surface, but we have to be especially attentive to areas of the body that would be most easily bumped or bruised. What happens in a skin tear is that it's usually a partial thickness wound, and we talked about how the epidermis becomes thinner as we age and there's less adherence between the epidermis and dermis. And in fact, what actually occurs is that the epidermis is peeled back from the dermis, exposing that capillary network that's within the dermis. Sometimes it can extend to and through the dermis, but as you would expect, one of the biggest problems is that once that capillary network is exposed, these types of wounds tend to bleed a lot, and so sometimes the patient will get very panicky. Sometimes the healthcare professional or the family caregiver will also get very panicky, but it's usually not that serious, even though it's quite painful because of the cutaneous nerve endings. So the first thing that we need to do, especially because they are bleeding a lot, is for us to promote hemostasis. And we can do that by applying pressure to the wound and elevating the limb if the skin tear is affecting the arms or the legs. Once the blood loss is under control, we want to cleanse the wound. And we want to do that in a way that's going to minimize any further trauma. So in general, the best cleanser for a skin tear is normal saline or water, but we want to make sure that the water is warmed to body temperature so that we're not causing discomfort and reflexive vasoconstriction. When we dry the wound, we can either let it air dry if it's not bleeding or gently pat it dry. We don't want to rub it because that can separate the skin layers even further and cause the wound to become larger. If possible, if there's a skin flap present, we want to try to get that skin flap back into place. The skin flap can cover the wound almost like a biological dressing. In many cases, it acts almost like a skin graft. It may readhere or it may actually slough off on its own as that wound starts to close. So the best way to get that skin flap back into place is to use a dampened cotton swab or a gloved finger. So you can dampen it with water, or you can also use a tiny bit of petroleum jelly. That's usually what I do. And then you gently push the skin flap back into place. Some of the literature will recommend the use of tweezers, but that's really, really tricky because that skin is so fragile that when you grab it with the tweezers, it may just break down. Next, we want to make sure that we're using some type of moisturizer to protect the surrounding skin. So usually it's something that's petroleum based or has mineral oil in it. But we try to keep the petroleum and mineral oil out of the bed of the wound itself because it can interfere with that current of injury. It's important in skin tears that we avoid the use of any type of medical adhesive like a tape or an adhesive dressing because the adhesives themselves can cause another skin tear or they can stick to the flap and cause the skin tear that's already there to become larger. So typically we choose a dressing that's non-adherent, so a non-stick dressing over the skin flap, and then we hold that dressing in place with Curl-X or gauze wrap. That allows us to tape the gauze to itself instead of taping it to the patient's skin. We also have to, throughout the course of care, as the wound dressing is removed and replaced, look out for any signs and symptoms of infection. To prevent skin tears, we should be looking at and addressing any types of environmental hazards. So some of that has to do with the patient themselves. If the patient requires education or the caregiver requires education and better methods of transferring, that's something that we should think about. We also want to make sure that the patient is educated in proper moisturization of the skin so that the skin is not as delicate and vulnerable to injury. We want to look at the patient's environment and make sure that it's well lit and that the furniture is positioned in a way that minimizes the chances of trauma. Sometimes the furniture will also need to be padded, like think about the bed. Like if you have a headboard or a footboard that has sharp corners, if that person gets up in the middle of the night to use the bathroom, for instance, they could bump into the edge of the bed, and that can cause a skin tear. Coffee tables, end tables, those types of things are pretty common areas that we have to watch out for. We might also consider the use of protective clothing like long sleeves or pants, or you'll see in this picture, they actually make arm and leg sleeves that you can use. Abrasions are another type of acute wound. They generally accompany things like falls or bumps, and they can affect anybody at any age. They do range in severity depending on the depth of the wound, partial versus full thickness, and the amount of surface area that's involved. A lot of times we'll see this because the patient's skin has had contact with the road surface, so road rash is actually a very common type of abrasion. It can happen through a car accident with an unrestrained motorist or passenger that's ejected from the vehicle or when a vehicle hits a pedestrian. We also often see this in motorcycle accidents and bicycle accidents. Abrasions, as you might imagine, have a high rate of contamination because the skin is being scraped away by something that's dirty, and so they have to really be thoroughly, carefully cleansed. So here's an example of a patient who's had a bicycle accident and sustained an abrasion to the right shoulder. Other things for us to think about as OTs and PTs are this wound will probably be pretty painful because there's exposure of superficial nerve endings, and in addition we have to make sure that there's no underlying musculoskeletal injury as a result of the trauma. But we want to think ahead. If somebody has a painful shoulder, what are some of the potential functional impairments that could come from limited mobility? And so how might that affect the person's occupations, and what can we do in advance to mitigate that? Degloving injuries are actually an avulsion injury where the skin and sometimes some of the underlying tissues are traumatically pulled away from the body. They are also typically caused by motor vehicle and motorcycle injuries, but also can happen in occupational injuries if the person's hand or foot or other body part gets stuck in a piece of machinery. So here's an example of a degloving injury of the left foot and one of the left hand. I don't know where the degloving injury of the hand came from, but I do know that the one on the foot was caused by a front end motor vehicle collision where the engine block actually came onto the floorboard of the car. The patient was trapped inside the car and had to be extricated. And when the person was taken out of the vehicle, the pressure from the front end collision actually caused the skin on the dorsum of the foot and toes to be pulled away, exposing the extensor tendons. So as you might imagine, that required a grafting procedure to close the wound and a lot of PT and OT to make sure that the person didn't have a whole lot of functional impairments later on. Wound dehiscence is a problem that we need to be aware of in patients who have had surgeries. Especially, this is a picture of somebody with wound dehiscence that is involving a total knee arthroplasty. And so wound dehiscence is where the sutures or the primary closure of the wound fails and the wound splits open. And here at the knee, you would imagine that that is very common because we're moving the body part a lot during the healing process to try to prevent some issues with range of motion and overall mobility later on. And so some of the factors that can contribute to wound dehiscence, we have to make sure that there's not an underlying infection. Also, those same comorbidities and medications that we talked about earlier, those could interfere with wound healing as well. So we need to keep an eye out for this, know what the risk factors are, so that we can modify our treatment approaches and hopefully prevent this from happening in the first place. We're going to next talk a little bit about chronic wounds, the four main categories that I mentioned before: pressure injuries, vascular wounds due to arterial and venous insufficiency, and then neuropathic ulcers. This is a picture of pressure injuries. As you can see, it affects the areas of skin overlying bony prominences and happens most often in patients that have impaired mobility. This is a picture of arterial ulcers. Arterial ulcers happen because of inadequate circulation to the distal portions of the lower extremities. So usually it involves the lower leg as well as the foot or the toes. These are venous ulcers. Venous ulcers also tend to affect the lower part of the leg, but you can see that their appearance differs from the arterial ulcers. What happens here is that when you have inadequate venous return from the legs, the skin, the legs will become very swollen and the skin thins out and may actually open up spontaneously or in response to very minimal trauma. Diabetic or neuropathic ulcers occur mostly on the bottom of the foot, but can also involve the toes. So some of the essential wound assessment techniques that we'll be talking about are measuring the wound so that we can see how severe it is and also determine what types of interventions might happen, and then also thinking about the related functional impairments. There's a time model of wound assessment that uses an acronym that helps to guide us through the steps that we need to take in order to have a thorough evaluation of what is going on with that wound itself. T in time stands for tissue. It reminds us to describe the bed of the wound. Is that wound bed granulating? So do we see evidence of new developing circulatory supply? Or is the necrotic tissue or dead tissue that's present in the wound that may need to be removed so that the wound can progress from inflammation to proliferation? I stands for inflammation or infection, so we're checking the wound and surrounding tissue for things like redness, warmth, swelling, odor, increase in exudate. M stands for moisture level, so we want to describe the type of exudate that's present and the amount of exudate. And then E stands for the edges of the wound. We're going to check for signs of healing or reepithelialization. We'll check for something called epiboly and also check for signs of too much moisture in the area, either from the wound exudate or from an improper choice of dressing or topical agent. So in terms of the types of necrotic tissue, there's two categories. The first is slough and the second is eschar. This is a picture of a wound where the bed is covered with yellow slough. So slough differs from eschar in terms of color and also in terms of texture. Slough, again, tends to be white or yellow. It's dead tissue, but it's also very moist. And so when you try to remove it from the wound bed, it tends to be somewhat adherent and stringy, and that may dictate some of the methods that we need to use. Eschar, in contrast with slough, tends to be hard, thick, and black, and it can be also difficult to remove. And so various methods would include the use of hydrotherapy, things like pulsatile lavage of the wound, sharp debridement where you're using a scalpel or a curette to remove the eschar or the slough from the wound. There's enzymes that can be used as topical agents that help to dissolve or soften this tissue so it can be lifted away. And then there are dressings that retain moisture that will help the body remove the eschar or slough by itself. That's called autolytic debridement. Here's what I was talking about before in terms of wound epibole. The E in the time model tells us to check the edges of the wound. Here we have the edge of the wound showing a rolled appearance. And the reason why that's significant is that that rolled appearance comes from new epithelial cells that are trying to migrate from the edge of the wound to cover the defect, but something's stopping them from coming across the bed of the wound. So instead they start to turn under or curl under at the edge of the wound. And so it's first of all a sign of a chronic wound, so the wound's been there for a while, but it's also a sign that something in the wound bed itself is stopping the new cells from migrating. And so that could be a dry wound bed, or in this case, it could be inadequate granulation tissue mixed with some slough. So that'll help us determine what the best course of care is for that patient. This patient will need some type of debridement of the slough, also some type of debridement at the edge of the wound to stop that curled appearance from continuing, and they probably need a change in the type of dressing that's being used. In terms of exudate, remember that exudate is the fluid that's being put out naturally by the body as a result of the wound. And so there's 4 different descriptors that we generally use to document the type of exudate that's coming out. Serous exudate tends to be thin and clear. Serosanguinous exudate is a mix of blood and serum, and so it tends to be pink and is also somewhat thin. Sanguinous exudate is bloody, and then purulent exudate is a sign of infection. Dead blood cells and bacteria cause purulent exudate. It's thicker, it may carry an odor, and it's usually white, yellow, or green. Next thing that we need to describe is the amount of exudate. Scant or minimal exudate means that there's hardly any fluid, if at all, coming out of the wound. So that wound bed tends to be kind of dry, and that'll help direct our choice of dressings to something that's hydrating, that adds moisture. Moderate amounts of exudate, and then we can have copious amounts of exudate. Like that, copious amounts of exudate might often be seen in things like venous insufficiency ulcers, where there's lots of fluid congestion in the affected limb, and that fluid is coming out through the surface of the skin as well as the surface of the wound. And so you see a lot of clear, serous exudate, and that needs to be absorbed so that the surrounding skin does not become macerated. Staging of wounds has to do with assessing the depth of the wound. Wound staging is most commonly used with pressure injuries. There's the National Pressure Ulcer Advisory Panel guidelines that are used. Also, diabetic foot ulcers have a separate grading scale. The most commonly used scales for diabetic ulcers are the Wagner scale and the University of Texas staging system for diabetic foot ulcers. However, unless it's actually a pressure injury that we're dealing with or a pressure ulcer, it's usually best to describe the wound by the type of damage that's present with reference to the layers of the skin. So partial thickness wounds that involve the epidermis only, or the epidermis and part of the dermis, or a full thickness wound where both the epidermis and the entire dermis have been affected. So here's an overview of the National Pressure Ulcer Advisory Panel staging categories. In a stage 1 pressure injury, the skin is still intact, so there's not really an open wound, but it is good for us to note that there have already been adverse signs there's already signs of an adverse reaction to extended or excessive pressure over the bony prominence. So a stage 1 pressure injury, no open skin, but there is usually warmth in the area, and there's something called non-blanchable erythema. What that means is that the skin is red, and when you press on it, normally when the skin is red and you press on it, it blanches or turns white. Here it doesn't because it's been damaged by the pressure. A stage 2 pressure injury is partial thickness, so it involves the epidermis, but the dermis is intact. In a stage 3, it's a deep partial thickness injury. So stage 2, superficial partial thickness, epidermis only. Stage 3, deep partial thickness, epidermis and part of the dermis, but the underlying subcutaneous tissues are intact. A stage 4 pressure injury is full thickness. It goes all the way through the epidermis and the dermis, and it does affect the underlying tissues. So it will affect the underlying fascia, sometimes the muscle, right down to the bone. When we measure a wound, the dimensions that we have to take into consideration, besides the layers of tissue that have been involved, is actually a numerical measurement that involves the length of the wound, the width of the wound, and the depth of the wound. We also look at the edges of the wound to make sure that there's no damage that extends below the surface of the intact skin. So sometimes, especially in pressure injuries, they describe it as the iceberg effect. What you see in terms of the opening to the surface of the skin is actually only the tip of the iceberg. There's a lot of dead tissue underneath, and the wound margin may actually extend beyond what we can see with the naked eye. So when we're looking at dead space, we're looking at things like undermining, sinus formation, and tunneling. So here's an example of the use of what we call the clock method for wound measurement. And the clock method refers to using the longest portion of the wound from the 12 to 6 o'clock position to measure the wound length, and then placing the measurement instrument perpendicular to that 12 to 6 position, and then measuring the widest portion of the wound from 9 to 3. Here's a picture that demonstrates what undermining looks like. So we can see there's a wound that's visible from the outer surface of the skin, but that cotton tip swab shows the dead space, the area of the damage that actually extends beyond the margin of the wound underneath the skin. Here's a video that you guys can watch that demonstrates the wound measurement technique using the clock method. The next thing that we should be thinking about, and sometimes we'll do this before, so the order can really vary, but we want to make sure that our wound assessment includes circulation, so to make sure that the wound is getting adequate blood supply, oxygen, nutrients, the cells that it will need in order for it to generate tissue repair. We can do certain tests for circulatory assessment, like capillary refill, looking at peripheral pulses, and then there are certain special tests. There's something called the ankle brachial index, or ABI. That's where the systolic blood pressure at the ankle, either in the posterior tibial or dorsalis pedis artery, is compared to the systolic blood pressure in the brachial artery. If you have good peripheral blood flow, the systolic blood pressure in the arm should be equivalent to the blood pressure in the leg. And so when you create that ratio, it should come out pretty close or equal to 1. In patients that have peripheral vascular disease, where the systolic blood pressure in the leg becomes less than the systolic blood pressure in the arm, when you create the ratio of systolic at the ankle versus systolic at the brachial artery, what you find is that it falls below the level of 1. And so this number is generally used as a cutoff for determining whether or not the patient has impaired peripheral circulation or peripheral vascular disease. And in general, the number that is used as that cut point is 0.8. There's special tests that we can do based on the positioning of the limb, and those tests are the Ruber of dependency test and the venous filling time test. If the Ruber of dependency test is positive, it's indicative of arterial insufficiency. And if the venous filling time test is positive, it's indicative of venous insufficiency. Next, let's talk about some of the interventions that are used, starting with wound irrigation or cleansing of the wound, and then discussing some of the common types of dressings that are used. When we clean the wound, we always want to clean it before we measure it, because dead tissue and debris in the area can obscure the true extent of the wound. We also clean the wound during dressing changes and after any type of debridement or intervention where we're going in and taking out that dead tissue or debris. Unless the wound is really infected or grossly contaminated, we want to choose a non-cytotoxic wound cleanser, and the most commonly used substance is saline. And the reason that the picture of the eye is here is that I was told, and it always helps me remember, that we don't want to put anything into a wound bed that we wouldn't put into our own eye. So that seems extreme, but when you think about it, saline in your eye, okay. Hydrogen peroxide in your eye, not so much. The exception of this is for acute wound care. Like when you do have an acute abrasion or like a really dirty laceration, obviously the the priority is to rid it of foreign substances and any infectious agents. So, in short term acute wound management, the use of things like hydrogen peroxide or some other type of antiseptic is okay. It's that when we repeatedly use it over time, it damages the good cells and stops the wound from healing. So, when we're choosing a dressing for the wound, we always want to dress for success. And what that means is that we're dressing the wound in a way that's going to facilitate the wound healing cascade. And again, we try to make sure that the wound has adequate moisture. So it's not too dry, not too wet. Things that we need to think about when we select an appropriate dressing is the cause of the wound. When we talk about moist wound healing, there is one exception. If the patient has a wound because of arterial insufficiency, what that means is that the wound has developed or failed to heal because there's inadequate blood supply. And so unless that blood supply is surgically restored through something like a lower extremity arterial bypass, then that wound is never going to close despite what we might do. And so we want to avoid making the wound any larger than it already is, or adding moisture to the wound that can encourage the proliferation of bacteria. So the exception with arterial wounds is that prior to revascularization, that wound should be kept dry and protected. And so typically they're covered with a dry, sterile piece of gauze. Also, just like the skin tears, we don't want to apply any types of adhesive to the skin of somebody with arterial insufficiency because it can cause the wound to become larger or can cause further trauma to the skin. So we tend to stay away from adherent dressings, and also whenever possible, we tape the gauze to itself rather than taping it to the person's skin. Next, if it's not an arterial wound, we will consider the moisture level. So if you have a dry wound, you'll want to choose a dressing that adds moisture, or if the wound is wet, we need an absorbent dressing, something that's going to wick away the exudate so that it doesn't cause damage to the surrounding skin. If there is dead space, like we saw with the picture of the undermining, that dead space needs to be filled in through the choice of the dressing so that the wound is encouraged to heal from the base of the wound to the surface. The problem with undermining and other types of dead space is that if the surface of the wound closes prematurely before it has a chance to fill in from the base, the hole that exists underneath the surface of the skin can collect fluid and bacteria, and the person can either get a systemic infection or that wound may form into an abscess. And you can see dehiscence, or the wound bursts again. Other factors to consider: there are certain dressings that help us fight infection. They can also help control odor. And we need to consider how much pain the person might have when the dressing is being changed. Is there another intervention that we might consider that will limit the patient's discomfort? So usually pain at dressing changes comes from the dressing sticking to the wound bed. So what can we do to prevent adherence of the dressing in the first place? So some of the types of dressings that absorb moisture when you have a wet wound, a wound that's putting out exudate, are gauze, although that is probably the least absorbent, hydrocolloid dressings, which cannot be used in infected wounds, alginate dressings that are actually contain seaweed, and so they look like felt when they're dry, but when they absorb moisture from the wound, they form almost like a gel. And what's nice about them is that they are moderately absorbent, but they don't stick when you take them out. And then finally, there's foam dressings. Some types of dressings that hydrate and add moisture include hydrogels and honey. Hydrogels come in two types. There's an amorphous hydrogel that usually comes in a tube. It's a gel, obviously, because it's called hydrogel, right? It comes in a tube, and you can squeeze it out onto a piece of gauze and place that into the wound. And then a sheet hydrogel is just like it sounds. It is a sheet of, it almost looks like thick, clear contact paper. It's sort of rubbery, but it feels wet, and it's very soothing, especially for superficial burns and often used in abrasions. Honey dressings are pretty nice because they add moisture, but they also help to maintain good infection control, and they tend to minimize scarring. If the wound has exposed tendons, ligaments, nerves, or joint capsule and fascia, we have to make sure that those biological tissues are kept moist. If those tissues dry out, they are no longer viable and they'd have to be resected, which you can imagine will have functional implications. We also want to pick a non-adherent dressing that doesn't leave behind any fibers or residue when the dressing is changed. So some types of dressings that you might commonly see in wounds that have exposed structures like this are something called inert gauze. Inert gauze is a gauze that has petroleum or paraffin, and so it's kind of slippery and wet, and it needs to be covered with a secondary dressing, but when you pull it out of the wound bed, it won't stick to the biological tissues. Again, you'll see honey dressings or saline moistened gauze. Saline moistened gauze can become problematic in case it dries out. They dry quickly. If you do go to do a dressing change and you find that the dressing is dry and adherent to the wound bed, what do you think is the best intervention? Yes, you can simply wet the dressing, so moisten it again with saline before you pull it out. Unfortunately, some people forget about that and they try to pull the dry dressing out of the wound bed, and it causes a lot of pain for the patient, and it can also damage the tissues. Some of the dressings that can help control odor from the wound contain charcoal, and so there's various types of charcoal added dressings like charcoal foam and charcoal alginate. There's also something called cadexomer iodine. It comes as a paste or a powder. One of the precautions with the use of iodine is that we have to check to make sure that the patient doesn't have thyroid disease, which would be a contraindication. And also we have to be careful with dosing. We don't use cadexomer iodine in patients that are less than 12. And also in adults, we don't want any more than 50 grams applied at once, and no more than 150 grams a week. Silver is also a dressing that helps to fight infection. It can be applied as a topical agent. Very often in burns, you'll see an ointment used that looks almost like frosting. It's called silver sulfadiazine or Silvadene. And then you'll see silver-containing dressings like silver foams, silver alginates, and hydrogels. And silver is a broad-spectrum antimicrobial, excuse me, which means that it is effective against many different types of bacteria. But they discourage us from using silver prophylactically because right now we don't know of any silver-resistant strains of bacteria, but we don't want any to develop either. And then honey, as I mentioned before, also is a broad-spectrum antimicrobial. Non-stick dressings, you can see non-stick gauze like Telfa, the inert gauzes that I mentioned in terms of covering tendons and ligaments, and then honey is also non-stick. Things to consider often when PTs and OTs get involved in wound care, we have to make sure that the person has adequate pressure redistribution. And the most common areas where this will happen is patients who have a pressure injury or patients that have a wound from a prosthetic or somebody who has a wound on the bottom of their foot. So in terms of pressure injuries, we mentioned that pressure injuries occur most over bony prominences, so we have to make sure that we're very careful to protect these areas. And you can see that the bony prominences that are most vulnerable will depend on the position of the patient. So in supine, we have to watch the occiput, the elbows, the heels, the sacrum, also the posterior aspect of the scapula. In side lying, the ear, again, the shoulder, the elbow, the hip, the lateral surface of the knee, also the head of the fibula, the lateral surface of the ankle or over the malleoli, but also the medial aspect from the two legs coming together. So often we'll position the patient in side lying with a pillow between the knees. And then you'll see sitting in the wheelchair. One of the areas that we do have to watch, depending on the depth of the chair and the length of the footrest, is the back of the knee and the patient's heel. In bed, one of the biggest risks for patients is when we elevate the head of the bed. And so when you elevate the head of the bed, very often you'll see the patient start to slide down in the bed, and that encourages friction and shear forces on various aspects of the body, especially over the sacrum, the ischium, and the back of the heel. And so whenever possible, we want to try to keep the head of the bed below a 45-degree angle. And when we do elevate the bed, if you also bend the knees a little bit, that might help the patient stop from sliding down. Turning and positioning needs to be individualized, but there are some common guidelines. The common guidelines are that when the patient is lying down in bed, they should be turned or changing positions every 2 hours, and also changing positions every 15 minutes when they're sitting up. That doesn't mean that every 15 minutes, if you have a patient in the wheelchair, they have to come out of the wheelchair. What it means is that we can teach them things like wheelchair push-ups and side leans. You can use a reclining wheelchair, anything that's going to help redistribute that pressure. This will also need to be individualized. So sometimes patients are on a specialized support surface, like an air fluidized bed where they don't need to be turned and positioned as often, or a special wheelchair cushion where they're able to sit for longer. Or you may have a patient that's very vulnerable and needs to be turned every 45 minutes versus every 2 hours. So you really have to think about the needs of that particular patient themselves.